we focus on the baby and not the mother.
Yeah.
And there's nothing wrong with that. I'm not here to blame the baby. It's just that traditionally, even the pregnant woman, the postnatal woman herself focuses on the baby. The family focuses on the baby. And therefore, naturally, the postnatal woman is neglected. Not deliberately, it's just how it has been for years. And because we don't focus on her, so she thinks that it's okay for her to cope as much as she can. And then another issue is that we've never really talked about the impact of pregnancy complications on long-term health. We've always just focused on these 8-9 months, right? It's only 8-9 months. She can tough it up. She can carry the baby. She will give birth and she'll cope. And because it's only 8-9 months, the focus is never on the woman. And because of the societal expectation, the family's expectation, her own expectation, ultimately, then she doesn't ask any questions. Is this normal for me? Should I feel like this? Should I really struggle with this?
We're very happy to have Professor Liona Poon join us today. She's a professor of obstetrics and gynecology with an academic subspecialist in maternal fetal medicine at the Chinese University of Hong Kong. She's internationally recognised for her dedication to improving maternal and fetal health and has an extensive research portfolio with over 300 peer-reviewed publications in high impact factor journals and an H-index of 73. For the past 20 years, Professor Poon has focused on developing strategies for the early prediction and prevention of preeclampsia. It is one of the leading causes of maternal and perinatal morbidity and mortality. Her vision extends beyond obstetric care to transform women's health globally through clinical research, education and advocacy, ensuring that early screening and prevention becomes standard practice across the continuum of care. Thank you so much, Liona, for joining us today. Really happy to have you here. The first question that comes to mind is we're talking about postnatal care. Can you tell us why is postnatal care so critical?
You know, when you talk about postnatal care, you just think about the baby, right? And you just think about the first few days after birth. But then, that's how I thought about postnatal care as well, as I was a trainee. And then I remember delivering the baby and hand the baby over to a pediatrician, and my job is done. And over all these years, and I've got to realize that postnatal care is really beyond the first few days after birth. It's about actually setting up a healthy future for both the mother and the baby. And perhaps I can break it down as to why I think postnatal care is so critical. First of all, as I mentioned, is process for the mother to recover. I mean, honestly, when I think of a pregnant woman, I think of the fact that bearing that child is a massive stress on the body. And then you just think that, okay, after giving birth and suddenly everything goes back to normal, but it's not so true, is it? I can see the struggle that all these postnatal women go through. And so hopefully, the postnatal care that we dream about is going to really help the mother heal physically, manage the discomfort, the pain, monitor for complications like heavy bleeding, infection, also addresses the emotional health, etc. Because I think postpartum depression and anxiety is quite a big topic right now. But of course, I'm always thinking about beyond that. I'm thinking about the fact that the body has been substantially stressed with the pregnancy. And then sadly, about 1 in 5 women have a complication during pregnancy. And I can only imagine that stress has a massive impact on a woman's long-term health. And then just let's say preeclampsia, which is a topic that is very close to my heart. And now I see it as the precursor to future cardiovascular disease, chronic hypertension. So it seems that having had a pregnancy exposes you, reveal the hidden problems that may present 20 years down the line. And, you get stressed and then you get this complication during pregnancy. And I think it's the same with diabetes as well. Because if a woman is predisposed to diabetes and then she gets pregnant and then she presents with gestational diabetes, and then that process is accelerated. I mean, instead of having diabetes maybe in 20 years and within 5 to 10 years of giving birth, and, the problem shows itself. So it's very obvious that what happens during the pregnancy, a complication happening during pregnancy, is not just a short-term concerns. So I'm thinking whether postnatal care has a place in optimizing the long-term health of the woman. If I were in the best case scenario, I'm able to prevent preeclampsia from happening. maybe I will, optimize the long-term health of the woman. Fortunately, my prediction model is not 100% prediction, it's not 100%, and I'm not able to prevent the condition 100% with aspirin, and therefore there's still women having preeclampsia. So for that group of women, I still need to think of strategies to reduce her future cardiovascular risk. So this is another aspect of postnatal health, postnatal care. And then I think all our focus is always on the baby, no doubt. The newborns, the babies are the future, and therefore that remains to be the core of postnatal health. But I wonder whether we can promote the idea of mother-baby care, not just baby care. If I say a woman, she's healthy, and then I think if the mother's well, then the baby's well, and vice versa. I think this is something that we have to really consider promoting. And then the last thing what I think we have to do much more on is relating to family support. Having a new baby is overwhelming. And so I hope that we can provide holistic postnatal care that is, in a position to support the family, support the mother and the newborn, and altogether then it becomes a much better experience. And hopefully then that would be beneficial for the woman's health as well. So I'm just thinking from a very broad perspective, not just the first few days after delivery. And because right now I think we are not really doing very well because there's only one visit. So, and that visit is perhaps quite light touch as well. Would you agree?
Everything you're saying just resonates so much. And because I think a lot of women do think that conditions that they may have developed in pregnancy go away after they've had the baby. And so it's really interesting how it's a window into their future health and how you're trying so hard to optimize their outcomes in pregnancy with the aim of optimizing their future health, which is amazing because that's really specific and tailored towards women's health and beyond just that pregnancy period. They often say it takes a village to bring up a baby. And I think a lot of that has eroded away with the pressures with funding and resources and staffing. So often those appointments are quite light touch, as you say.
Very light touches. I mean, Hong Kong is almost shocking. I think I call it an opt-in service, meaning that the single postnatal visit is not even advertised. Apparently, the clinic will slip a piece of paper in the folder. And if the woman captures that, okay, I can have the postnatal check. If she doesn't see it and it doesn't happen, and then at most, I think they just will check on your lochia and breastfeeding, and that's it really. And it's pretty depressing to hear. And I can imagine that all the focus is on the newborn. I appreciate that. As I mentioned, the babies are the future, and then therefore it makes a lot of sense to ensure that the initial part of life is well taken care of, because obviously in the old days, neonatal death is a massive issue, but not anymore. And so perhaps we have the capacity to also check on the mother. But I've been told that in our setting, no, there's no capacity to check on the mother. We can only focus on the newborn. And so I was referring to the fact that, yeah, if the mother's well, hopefully the baby's well, and vice versa. I think that this mother-baby diet relationship is so important for us to recognize. And I'm just thinking, I don't know why it is so difficult for people to, I mean, if you remember when you were undergoing training, you catch the baby and then it's no longer my problem. But my view has completely changed because I see all these postnatal women in my clinic and the struggle that they go through. And then I talk about, eating well, sleeping well. They laugh. They're like, are you kidding me? When am I going to find time to sleep more? I need to breastfeed. I need to wake up every 2 hours, et cetera, et cetera. How can I make sure that I lose the weight that I've gained over the weeks during pregnancy, et cetera? So I just wonder, we're just simply not hearing their problems. And because we tend to think that women are super women, they can have babies, they can breastfeed, they don't need to sleep, and they can take care of their family, they can have a job. So all in all, we create this culture whereby, we make these postnatal women think that it's okay to tough it out. It's okay not to address the lack of sleep issue. It's okay to eat poorly because they expect us to be the superwoman to take care of everything, right?
Yeah, I think a lot of it's unheard. And because we don't routinely have postnatal clinics, So only some trusts will have that, and the type of postnatal service we have. But you're right. I think the focus is more on the pregnancy and birth aspects, really. There's so much to cover in terms of like how postnatal health is critical, important. If we focus on postnatal health, if you have got hypertension in pregnancy, what has that impact on mothers, would you say? So say I was a mum and I developed hypertension in pregnancy, and postnatally I didn't have any hypertension and I came off the medicines that I might have had during pregnancy. Is it all gone away? Is there any kind of impact on me for my future health?
It seems like a very simple question, but then I think is a massive question, because we probably have to go back to the physiology of pregnancy, something to bore you with a little bit, because something that we learned many years ago, and then I don't think about it anymore. And then, as I was referring to the fact that pregnancy is a stress test, right? And then someone would describe like a marathon. It's like you run a marathon every day for 9 months, and then it really, pregnancy itself completely transforms a woman's body in ways that, you've never thought about. You know it because you're a doctor, but then somehow you still forget it, right? And then the physiological changes that the heart goes through. I have to focus on the heart, because imagine the pregnant woman will have to pump a lot of blood through the body, support the placenta, support the growth of the baby. You can just imagine the heart needs to work so much harder. And then, the heart pumps up blood to sustain the pregnancy. The heart rate goes up, and blood pressure goes down, because there's a need for the blood vessels to relax. So to cope with the pregnancy, all these changes put a huge drain on the heart and the blood circulation. And somehow, I think this process can reveal hidden health issues, as I was referring to. If you're predisposed to cardiovascular disease, let's say in 20 years' time, and then you may suffer from preeclampsia, which is a hypertensive complication of pregnancy. It's not just about hypertension. It's quite extensive, because there could be multi-organ dysfunction involving the liver, kidneys, clotting, even the brain, etc. So that's, for me, is obviously is something I've been focusing on for the past 20 years. And now I've gone beyond just predicting and preventing the condition during pregnancy. I'm thinking of the impact of having had the condition during pregnancy. And, in 5 years' time, perhaps a woman would have new onset chronic hypertension. So what does it mean to a pregnant woman to suffer from preeclampsia? Unfortunately, there's a lot of evidence out there suggesting that having had a preeclampsia complicated pregnancy, then the chance of future problems beyond just chronic hypertension happening outside of the pregnancy situation, then there's a fourfold increase in risk of heart failure. The heart doesn't work so well, almost double the chance of having stroke, and then double the risk of irregular heartbeat, coronary heart disease, like a heart attack, that kind of condition. And in the worst case scenario, I mean, as I mentioned, I've always focused on what happens during the pregnancy. And now I also know that beyond pregnancy, having had preeclampsia increases the chance of death by twofolds compared to women without preeclampsia. I know I'm here to shock some of you, but I hope I'm not putting you off from having a child, because obviously it's still a minority of women having these conditions. But still, I'm really hoping that by developing solutions to predict and prevent preeclampsia during pregnancy, I can substantially optimize health for some of these women. That's something for us to bear in mind. So obviously, it's extremely important for me to try my best to predict and prevent preeclampsia. And unfortunately, that happens. And then hopefully that, as I was alluding to, the fact that we could use the postnatal period as a window of opportunity to prevent future cardiovascular disease. And perhaps we'll talk more about that later on. So I think what is important for us to think about is what happens during pregnancy, prevention, as I mentioned, and also it's a massive issue for us in Asia, and perhaps also the case in the UK as well, in terms of physical activities during pregnancy and in the postnatal period. It seems that everybody's so nervous about exercising. And can you just imagine, as I was talking about the fact that having a pregnancy is like running a marathon every day for 9 months, and you you basically lead a sedentary lifestyle, more or less. You do nothing. You you get up and go to work, and that's about it. And for the first 3 months, in a lot of cultures, actually, we're encouraged to do very little, so to protect the pregnancy. I think that concept is unfortunately very ancient, and then it's not easy to change. And then even with the WHO recommending the fact that pregnant women, postnatal women should have regular physical activities, but still we're not able to change this. So I just want us all to think a little bit about, I'm pregnant, my heart is working excessively hard to sustain the pregnancy. I don't lead this sedentary lifestyle. I lose my muscle mass. I don't officially support the health of the heart because I don't exercise. And then I mean, obviously that in itself would pose a massive risk on future cardiovascular health. So I think something for us to think about is, yes, I'm promoting prevention and during pregnancy and actually postnatal period, as I was mentioning what my patients are like, I don't have time. How am I going to go back to my best body weight? I don't eat well. I don't sleep well. As you know, sleeping poorly is a risk factor for cardiovascular disease, right? And so all of these bad stuff that are happening during pregnancy, and we're not able to promote healthy lifestyle, regular physical activities. We don't even talk about nutritional health. I don't know whether that has changed in the UK. I left 9 years ago, but certainly I don't remember seeing any about eating healthily, nutritional guidance, etc. But in Hong Kong, that doesn't happen. But then I think eating well is also extremely important for promoting heart health during pregnancy and during the postnatal period. So all these things that are very worrying. And then I found that having had a complication in pregnancy, be it preeclampsia or gestational diabetes, during the first year postpartum, you expect postnatal women to lose the pregnancy weight, right? But in reality, it doesn't happen, does it? And I'm actually seeing the body weight going up during the first year postpartum. It's quite shocking. And I've also compared the data against pregnancies without complications. For sure, pregnancy without complications and body weight comes down. But then for those having had a complication, then the body weight goes up. And we all know that body weight, obesity, and they contribute substantially to metabolic syndrome, diabetes, cardiovascular disease, etc. So it's like a vicious cycle, right? Pregnant woman gets preeclampsia, and then there's a difficult birth, and then postnatally she's not keen on breastfeeding. That's also another issue amongst this particular group. It's difficult for them to sustain breastfeeding, and then they don't sleep well, they don't eat well, and then the body weight goes up, and then there she goes, she gets pregnant again. So it's a never-ending vicious cycle. And so I just wonder how else we can help these women. And so I think ultimately there has to be a paradigm shift for us to really change the way we see postnatal care, postnatal health. And as I mentioned, that this is perhaps a very critical window whereby we could really alter the cause of not exactly a disease, but then the cause of the cardiovascular health for these for these women in the long term. I hope I'm not shocking you too much.
I think so part of the whole premise behind this is to make sure there is no misinformation, and you are doing so much world-leading research in this area. So it's so great to have your input on this. And I think a lot of women aren't aware of these things because lots of women are very motivated in pregnancy, I find. You probably notice the same as you say, often prioritize baby. And then postnatally, they're often thinking of themselves the last. So just knowing that, there's certain things that they can do to improve things in pregnancy, but also trying to raise awareness of why those things such as nutrition and exercise and physical activity, and not the pressures of losing weight as such, but the trying to get to the best physical weight to optimize their future health. And I think sometimes these messages aren't conveyed very clearly and lots of people aren't aware of it. I do know there's probably a lot of work in terms of now there's more emphasis on being more physical during pregnancy. So that bit has changed a bit, and lots of women are trying to maintain, especially those who are used to a level of physical activity already and exercise and strength training, more of the advice is to continue with what they're used to
not pick up a new sport that might put themselves at risk of injury, but trying to be more physically active. And I think there's a lot more guidance because there's a myth about eating for two. So there's less of an emphasis on the amount of weight that you have to gain, especially if you enter pregnancy already at a higher weight or a higher body mass index. So I think more of the recommendations are to try to keep it as stable, not to lose weight, but to keep it as stable as possible. I do wonder, a lot of your research has been focusing on what these incredible changes that women's bodies go through. And physiologically, they go through these changes just to adapt because they're having a baby, but that they can change a lot more and to a different scale when there is something like hypertension. So there's a big spectrum. So some women might have hypertension just towards the end of pregnancy, and some women have the whole full-blown preeclampsia where it might affect more of the organs and they might need an earlier delivery. Is there a very different outcome in terms of long-term health for that woman if they were on the milder end of the spectrum versus on the more severe end of the spectrum?
Yes, sadly, I think if, let's say, a woman has severe early onset preeclampsia, she's definitely more at risk of future cardiovascular disease in comparison to someone having just slightly raised blood pressure at term. That's quite evident. So the more severe the hypertensive complication, the higher the risk of future complications. So, but then in my research, I haven't really teased out all the details in terms of the degree of injury to the heart. Because what we're doing is that throughout the pregnancy, we follow these women defined as high risk, and then we treat them with aspirin, 150 milligrams nightly from 12 weeks till 36 weeks. And obviously, we're lucky we're able to prevent some cases of preeclampsia, but some would continue to develop preeclampsia, and we're definitely seeing a difference between, high-risk women with or without preeclampsia. We can see differences in the heart changes because we do the heart scan during pregnancy. We can see the heart really struggling to pump blood through the body to make it, easy way to understand. And then, as you can see, video here that on the left, this heart is much thicker. There's what we call concentric hypertrophy. The heart muscle is much thicker, so the work that the heart needs to do to pump is greater in order to sustain the pregnancy, in comparison to the heart on the right that is less thick and it's less struggling, so to speak. And then we have other parameters as well to look at the pumping function, the systolic function, and the resting function, the diastolic function, and certainly the resting heart is more stiff. And these features are potentially present from before pregnancy, but then there aren't many studies on that topic. But then my focus has always been longitudinal data from early pregnancy till term. And now I even have data up to 1 year postpartum. And what we see is that for women with a history of preeclampsia and heart changes persist till 1 year postpartum. So the recovery probably starts by 6 months postpartum and is very, very gradual. So it's not, as you were saying, blood pressure normalizes, let's say, by 6 weeks postpartum and off she goes. But actually her body hasn't fully recovered. And now I can say that the recovery is still ongoing by 1 year postpartum. That is quite shocking. I have no idea for how long these changes will persist. And unfortunately, I'm no longer funded for my project to go beyond the 1 year, but I'm sure there will be other researchers coming along with more data. So yes, even the blood pressure normalizes by 6 weeks postpartum. Perhaps we believe that has normalized because, as you know, the definition of hypertension is 140/90. And then recently, I was a bit shocked with some data because the systolic cutoff of hypertension, 140, is actually based on male data, and then we found the equivalent based on female data, and it's 110. So I'm not saying that we need to start treating women with blood pressure level 110, but certainly if we are using male specific cutoff to define hypertension in women, we are perhaps missing significant opportunities to optimize long-term cardiovascular health for women. Obviously, we will never know whether we need to start treating women when blood pressure when the blood pressure is above 110 is perhaps too far-fetched right now. But if you think about it, we diagnose preeclampsia, hypertension in pregnancy with a cut of 140/90. Perhaps we should start thinking about when when the blood pressure is 120/80, exceeding 110/70, we are missing opportunities really. And so I'm learning lots, and we also know that hypertension is really the key risk factor for future cardiovascular problems. If we take hypertension, such an important risk factor, but I don't know whether we take it seriously enough, even in pregnancy, right? So, because I can see my colleagues only treating when the blood pressure is exceeding 140/90, and they treat when blood pressure is exceeding 150/95. For me, it's too late. I think we should treat the moment we diagnose somebody with hypertension, 140/90, with lower doses of antihypertensive agents, and so to kind of titrate the drugs up so that we have more room for treatment. Because when hypertension is already 150/95, maybe you don't have the time to treat it properly, and then you give up and say, "Oh, I'm unable to control the hypertension because it's too late." But
So
yes,
so interesting. I mean, historically, so much of the data that's used to treat women are extrapolated from men, and I think that is in a lot of different areas. Just going back a bit to, the video that you were mentioning. At what time point was this taken? Was this at diagnosis or just right at the beginning?
this is not first trimester scan, but this is certainly weeks before preeclampsia presents.
So that is so, yeah. So you actually have the changes before there's a clinical diagnosis of preeclampsia
Yes.
in terms of so the heart has remodeled to be having a much thicker muscle around that big chamber, the left ventricle. Oh, that's so interesting because with a lot of the guidance around the antihypertensive, so the medicine treat for blood pressure, there's a lot of movement towards the ACE inhibitor, particularly in the UK, enalapril as one of those more first line agents because there's some association with it help to remodel the heart. Is that something you guys do in Hong Kong and advise for, or not really?
Not at the moment. I think well, it'll be very important to see data and treatment with ACE inhibitor, and you follow up these cases with echo evaluations so that you really can see the impact on the heart. Because it's not so easy, I have to say, when we practice in obstetrics. A lot of stuff that we do, a lot of the things that we do is not evidence based. But then I think I'm seeing a change. I'm seeing that there is a drive for us to generate high quality data to inform clinical practice. So yes, I think it would be good. I mean, even though we know that ACE inhibitor can remodel the heart and all that, but then is there sufficient data involving pregnant women? What does that mean to treat a pregnant woman with an alpro? And then afterwards, what happens to the heart? I would be fascinated to find out. I know I'm not so easy in terms of kind of making a decision. Okay, I'll jump and move over to a new drug. I think the challenge is that if we don't have that view, that we never have the data sufficient enough for us to change clinical practice, if you know what I mean. So I know in many parts of the world, okay, let's say in this country, okay, because the UK is doing it, so we'll do it. And then that's quite common. But then we miss opportunity to generate data to change clinical practice. Exactly what happened with preeclampsia screening. If you remember, like NICE recommendations were issued in 2004. And then, of course, it's fantastic to have the recognition that we need to screen for preeclampsia. But the evidence is actually not very strong based on all the risk factors, because I've never seen a study using the NICE recommended approach and then treating high-risk women with aspirin and seeing the effect of that. There is no such data out there.
It's so tricky in this this subject and also this topic with obstetric patients and postnatal patients. But yes, no, agreed. A lot of the practice is based on the best available evidence, and I think, as you say, this research is very much needed.
But
And then, sorry, you were saying?
no, it's just challenging how you find the right balance. But I think ultimately, if let's say you decide to adopt this particular drug and you have a systematic way to collect the outcome data, there's a possibility that you can still audit the outcome of this change and compare with historical data. At least you generate some evidence to see whether you are actually improving outcome, while other research groups will be pushing for, a randomized controlled trial and generate the best quality evidence to inform clinical practice. So yeah, I'm sure somehow for obstetric care, postnatal care, you have some retrospective data, you have some prospective data. It's a mixed bag of data out there that could guide us in terms of how we can go forward.
No, so right now for postnatal care, it seems to be such a critical period to optimize women's health. And as you say, there isn't a very robust program anywhere that I know of that really tries to do this. And why do you think it's so neglected? And what do you think we can do about it?
I think the challenge that we face is that because we often focus on short-term gain, or that I've already highlighted the fact that we've kind of focused on the baby and not the mother. And I think there's nothing wrong with that. And then I'm not here to blame the baby. It's just that traditionally, like even the pregnant woman, the postnatal woman herself focuses on the baby. The family focuses on the baby. And therefore, naturally, the postnatal woman is neglected. Not deliberately. It's just how it has been for years. And because we don't focus on her, so she thinks that it's okay for her to kind of cope as much as she can. And then I suppose there's another issue is that we've never really talked about the impact of pregnancy complications on long-term health. We've always just focused on these 8-9 months, right? It's only 8-9 months. She can tough it out. She can carry the baby. She will give birth and she'll cope. And because it's only 8-9 months, and therefore the focus is never on the woman. And even though she's all puffed up and then she's struggling to carry the pregnancy, and then postnatally she struggles to sleep and she struggles to breastfeed, but somehow she kind of continues because the society expects her to continue. And I think because of the societal expectation, the family's expectation, her own expectation, ultimately, then she doesn't ask any questions. Is this normal for me? Should I feel like this? Should I really struggle with this? Perhaps she doesn't think like that anymore because she has no capacity to think like that. So it's up to us to help these women think a bit, right? And then, so I think everyone's expectation is quite challenging for the woman, for us to change the way we see the postnatal period. And the fact that we also offer this one follow-up visit, and because it's the expectation, okay, and therefore nobody ever thinks about the fact that the body doesn't quite go back to how it was. And then, okay, 6 weeks postpartum, blood pressure's normal, and okay, everything is healed except for cesarean section, of course, if it's a vaginal delivery, and then the perineum has healed from either the cut or the tear. And yes, externally, the woman looks back to normal. She looks like she's back to normal, other than the weight that she's gained. And okay, she'll be able to lose the weight somehow. So the one visit seems to be the norm, and therefore we have not really visualized what we can do beyond that one visit. And you've highlighted the issues because there's no consensus as to how best we should deliver the postnatal care, short term, medium term, long term. And therefore, given that there are no guidelines out there, at best, with the work that we've done with FIGO, which is the International Federation of Gynecology and Obstetrics, our biggest federation in our field. I mean, we've created a number of best practice advices in terms of how we can optimize long-term health in relation to preventing cardiovascular disease, diabetes, managing obesity, etc. We've created those best practice advices, and I mean, meaning that we don't have high quality evidence to write proper guidelines because we've written best practice advices, but then that's a start. raising awareness is a start. And so hopefully we've made a start, we've raised enough awareness, and now we really have to champion and try our best to fill this gap. We need to find ways of generating more evidence, high quality evidence as to what we do during this postnatal period could impact on long-term health. And so I think we can go on forever. I think I'm just thinking I can see the struggle that my postnatal women have to go through, and they stop by 6 weeks postpartum, they come to my clinic. They even stop breastfeeding because there's no way of them coping with the whole thing. The stress of recovering from a complicated pregnancy, the lack of support at home, and the crying baby, the lack of sleep, and then the thought of having to go back to work very soon, etc. And so all in all, that whole stressful situation, it seems even more stressful than the pregnancy. And then that adds on the postnatal weight, etc. And so what can we do? I think we've already made a start, raising awareness, writing best practice advices, even though we're not at a point of writing guidelines, because in order to write guidelines, we need to have high quality evidence. What do I mean by that? Ideally, prospective cohort studies to look at all the cardiovascular changes. And then in an ideal setting, we should do some randomized trials, evaluating whether, better physical health, better nutritional health is really going to improve the long-term health of these women. So we are very, very far away from kind of generating all these high quality evidence, but I'm also pragmatic. So I think we need to tackle these problems with different methodologies, not just being very fixated on randomized trials. I'm not, because I'm also doing implementation studies. I'm also doing feasibility studies, observational studies, anything that I can really do to generate the necessary data to at least inform clinical practice locally. And if we do this, and we can then collect more data to feed back into this program, and hopefully ultimately we could have a kind of bigger data set to write better papers and then to change clinical practice. So I think we've made a start, and step by step. And suddenly now we're talking about this, which is amazing. Yes.
Yeah. No, I think what is very clear is your passion about helping optimize health for mothers, and also this very neglected area of postnatal health. And I think what we're trying to do with this podcast is just to raise awareness that the postpartum period is a critical time frame where women are going through so much, and it's so easy to neglect them and neglect themselves, and other people neglect them, and there's no infrastructure or robust evidence-based practice about how to guide optimizing their health. But I think what you bring awareness to is that a lot of changes can still be there and not have completely changed by that 6-week postnatal period where they often get that light touch check-in, especially in the UK, and then also that it does carry on. And I think it's amazing that you're doing all of this work. And I think the next thing is for us to talk about what does this what the best practice guidelines are around. But no, I think it's amazing. And I think the take home is really that even though it's often, especially hypertension in pregnancy, it can be a big spectrum and there can be big changes. There are things that women can be aware of to try to optimize their health and try to improve things and for the future and in between pregnancies. So no, thank you so much, Liona.